So looking at cardiac output is something interesting and perhaps at the end not done as frequently as we should. The first question, is it useful to measure cardiac output? Well, it can be useful because indeed cardiac output is an index of tissue perfusion. We need some cardiac output, of course, to have a tissue perfusion. We may have some dissociation when cardiac output is already within normal values, but when cardiac output is very low, it is unlikely that the perfusion of tissues will be adequate. It is an index of the cardiovascular function, and as such, it's also quite important to evaluate at the bedside. And perhaps also very importantly, when we want to evaluate the response to therapy, we need to often measure the cardiac output. This morning we discussed the fluid challenge. Well, the fluid challenge is by definition increasing cardiac output. And if we don't measure it, we cannot be sure that indeed the fluids gave the results we expected from these. Just an example, in some own personal data, looking at the relationship between cardiac index and blood pressure. Well, very difficult to state that indeed we can be satisfied with a given level of blood pressure and that the flow will be preserved in these conditions. So no major relationship between the two. Even when you manipulate the system, we mentioned the fluid challenge, a very good example. Changes in blood pressure do not reflect the changes in cardiac output. So we may be misled when we say that we did not find any change in blood pressure in response to fluids, and then the fluids are not working. No, it could be, but we did not measure the good variable. The index in cardiac function is also very important. If we just look at the contractility, by echo or by other means, sometimes we may be thinking, oh, this patient may receive some dobutamine. Yes, maybe, because indeed, if we look back, we have a relatively satisfactory relationship between contractility, here assessed by ejection fraction, and cardiac index in patient with septic shock here. But if we look closely, we have these patients here. Cardiac index of 4 to 6 liters and depressed contractility. Should you give dobutamine to these patients as we discussed this morning? No. These patients already have a cardiac index of 4 to 6. It would not be helpful to have a cardiac index of 7 or 8 liters in these patients, of course. Here also, very importantly, just measuring the cardiac index and taking decisions only on cardiac index is probably not wise either, because in some conditions you have here a low cardiac index, but yes, a very high contractility. So again, giving dobutamine blindly here will not be effective. We need indeed to measure both factors when we want to give inotropic agents. We need to ensure that the low cardiac index we face is due to an impaired contractility. So we need to look at the whole picture and not only in cardiac index. And this will be probably the motto of my talk, is that yes, cardiac output is very important to measure, but to interpret it, we need to be looking just at not only at cardiac output, we need also to interpret the other data. Otherwise, we may be misled by our measurements. Is it important? Probably yes. If you look in septic shock, cardiac index, or here left ventricular stroke volume, is associated with the outcome of these patients. Ejection fraction is not, but cardiac index is. So it is a very good reason for trying to measure the cardiac output in your patients. So how to measure? How to measure? We have several ways to look at it, and you can look at this paper which reviews this in more detail. But we have indeed access to thermodilution. We have access to arterial waveform analysis, echocardiography, of course, ecography, Doppler. We have bioimpedance. We have many other techniques that can be found. The issue is basically, is these reliable techniques? This is, of course, one of the questions we need to address. And the second one, perhaps more importantly, what are the limitations of the technique I use? Because probably most of these techniques are working quite properly in many patients, but sometimes you may face patients where it is not that good. So the principle of thermodilution is quite basic. We inject a bolus of fluid or some heat exchange, and we measure the area under the curve here after detecting it in the pulmonary artery, or using transpulmonary thermodilution, we will measure it not in the pulmonary artery, but we will measure it here later on in the peripheral artery. But the principle is exactly the same. We have an area under the curve, which is representing the flow of the cardiac output of our patients. Well, the strength is that it is really reliable. I mean, it can be achieved in most patients. Only in a few patients we have issues. We discussed yesterday the patient under ECMO. Yes, indeed, we may have some issues there, but often it is quite reliable. We have very few limitations. Well, we still have some potential issues. And of course, we should be remembering that it is catheter specific. And sometimes we forget to use a good constant in our computer when you use a catheter, when you have several choices there. We need to pay attention to this aspect. Loss of indicator is, of course, very important. We need to ensure it is properly done. Signal-to-noise ratio is sometimes difficult, especially in severely hypothermic patients. And the most important limitation is that it is intermittent. It provides you information only when you measure it. So you do not have continuous assessment of the cardiac output. So it may be advocated to look at some more continuous evaluation, and the arterial pressure waveform analysis is probably very interesting, and probably one of the best demonstrations of the link between the waveform analyzed and the flow is based from this trial from Michael Pinsky, showing that indeed you have a very good relationship between the pulse pressure, but globally the arterial waveform and the stroke volume of these patients during clamping of the vena cava in the operating room. Importantly also, the pulse pressure is very nicely correlated with the stroke volume. So we say, okay, I just follow the pulse pressure of my patients, and this is a very good way to look at it. Well, the problem is that it is more complicated, because indeed, what is exactly the link between the arterial trace and the flow trace? And then we begin to, of course, have something interesting, because the flow trace is just during systole, and during diastole there is, of course, no flow. And so here we have pressure which is also present during diastole. And of course, the aortic compliance and elastance play a major role there in providing this pressure during the diastole. But the factors that will influence the arterial trace are quite multiple. Some of these have already been discussed, but it's important to look back at this when we will discuss the cardiac output aspect. And of course, the first part of the slope is mostly related to the stroke volume, because it is the eruption of the stroke volume into the aorta that generates this first part here. But we should not neglect the characteristics of the aorta also. Stiffness, elastance are very important, and even vascular tone may play a role there. And of course, for diastolic properties, it's mostly the aortic elastance that play a role there. And so it is not difficult to understand that when you give norepinephrine, the changes in pulse pressure and the changes in cardiac output are fully dissociated. One may say, and this was the message of the trial, that indeed there is some relationship here, because indeed the p-value is not so bad, between the changes in pulse pressure and the changes in cardiac output when you give fluids. Yes, but if we look at the scale here, and if you look at more realistic, if we can say so, just an increase up to 100%, so just doubling cardiac output with fluid. Doubling cardiac output with fluid is not very common, I agree. But nevertheless, if you look just at this area here, you realize that the relationship here at the individual level is totally misleading. You cannot draw any conclusion by looking at the change in pulse pressure in response to fluids, because it can be either no change in pulse pressure or decrease in pulse pressure for a close to 50% increase in cardiac output, or a doubling in pulse pressure for the same increase in cardiac output. No way to use it at the bedside, unfortunately. And this is just due because, of course, the different aspect of the arterial pressure, but mostly is that for the same stroke volume, you have different pulse pressure here, or different changes in arterial pressure for the same change in stroke volume here. and then this will be our problem for the interpretations there of the arterial trace and saying that it is proportional to the changes in cardiac output. The other very important aspect to take into account is the reflected waves. Jean-Louis Thébault already mentioned this aspect. I will look at another part of this. And the role of reflected waves change indeed the fact that we have not only the forward wave here, we have also the backward pressure here that comes, and the sum of these do the usual trace we see. Okay, but the problem is this may be affected by several factors. The first is, of course, the location at which you put a catheter, and so the morphology will be different. And so if you want to interfere cardiac output, just pay also attention to the place where you put your line. If it is a femoral line or a radial line, it may be, of course, quite different in these conditions. But perhaps more importantly, it will be affected by changes in vascular tone. Here, in these patients, constriction was induced by methoxamine, and you can see the changes in the morphology, in the pressure, and more importantly, the contribution of the forward pressure and the backward pressure were changing. And the same is true when you infuse nitroprusside and you dilate. You have a huge change here with a decrease in mean arterial pressure, diastolic pressure, and of course, the change of contribution of the forward one and the back pressure are markedly altered. And this will be, of course, influencing our patients also quite well, and of course, the measurements we have. And so, just measuring the stroke volume based on the pulse pressure is misleading. So, our devices do not do this. They do something more, which is they take into account the waveform itself, and this includes the reflection waves, and this is some way to look at the traces in a more clever way. And so there are several ways to look at it and to deal with this. We have the calibrated techniques that will try not to estimate the accurate cardiac output just based on the trace, but this will use the calibration to integrate all the factors at that time to say, I don't know what is affecting my pulse wave now, but I measure the true cardiac output, I calibrate it now, and then this will be, any change from now will be changes in cardiac output. And this is basically the PICO, the LITCO that do this. The other one are not calibrated, and we'll try to analyze in a more fine way the morphology to try to determine what will be the influence of vascular tone, what will be the influence of stroke volume by using some algorithm. So this is really the clue there, and which makes indeed the things quite complicated when you want to compare one to the other one. The PICO device is indeed using the transmural dilution to calibrate, we have already seen this, and the accuracy of this device is quite good, with a very good measurements here in patients with cardiac surgery and in many other conditions also. One very important aspect is that when vascular tone changes, this may induce some drift in the accuracy. And this was shown by the Jean-Louis Thébault team, and you can realize that the agreement here begins to be not so good already 2 hours after the first calibration. We need to pay attention to this, because often at the bedside, we say, okay, we calibrate 3 times, 4 times a day, and then we trust the measurement in between. But 2 hours is much closer than the first measurement that we expect. And so indeed, we can already see a significant drift there that occurs there. So recalibration should be the rule. Whenever you have a question to address at the bedside, you need to redo the measurements. And by the way, it will be interesting because you will also have these additional measurements. The LITCO is using, and it's outside here, and has been explained to you by different way. The curve analysis is somewhat different, and most importantly, they also calibrated using the lithium dilution, basically the same principle, and so it gives you also a very good reliability of this device. And interestingly, it will also be affected by the same aspect of the recalibration. You can see here, after a few hours, because of changes in vessel stiffness due to the or vascular tone, there will be some changes in the accuracy and need to recalibrate, perhaps more frequently than the manufacturers say. The flow track of VGLEO is a no calibration. The prom is more or less the same, but evaluation of the vascular tone by the shape of the arterial waveform. Basically, it's using this kind of a formula. It seems to be quite interesting. But so basically, the shape variables will be analyzed by a computer, and this means that basically what they looked at is not only the changes in arterial pressure here, which will be driving the stroke volume derivation, but also they looked at the kurtosis here, and they look at the skewness here to determine the impact of the vascular tone. Is it working, yes or not? Well, it is working yes and not, because indeed several versions were implemented, with initial versions shown to be not so effective in some conditions. The advantage is a rapid response time. Compared to the other techniques, it gives you exactly the same information here. You can see that the three values were exactly within the same measurements. The problem was perhaps nicely demonstrated here in this trial by Mathieu Biet, showing that indeed in patients with a high or normal vascular tone, there is good agreement. But when there is severe dilation, here it was indeed an underestimator of cardiac output. And this was just the impact of the reflected waves that were not taken into account properly in that version. So there was a new version implemented that we had a chance to evaluate. And so when evaluated this new version, you can see that indeed in this condition, it was much better. And that the impact in this new version of the vascular resistance was really minor in these conditions. So the advantage is really that it improves over time. It's relatively easy to use, and it's beat-to-beat analysis. The negative aspect is that several versions are used, and you need to be sure that you have the new version on board. And mostly there are no other measurements. And in complex patients, just having cardiac output, again, is not enough in many conditions. EV1000 is basically like the PICO. It's also transpulmonary time mode dilution added to the flow track technology in between several calibrations. And so it's exactly the same advantages and disadvantages as the PICO device. But the limits of this is really the fact that acute changes in vascular tone will impair the adequacy of these techniques. And what we have to do then is either to wait a little bit when we have an uncalibrated cardiac output device, meaning that we have some lag time between which we cannot make any conclusion, or we have to recalibrate if we use a calibrated device, which is, of course, very important to do at that time. ECO is the alternative way to look at the cardiac output. And of course, you can measure the stroke volume by looking at the flow into the left ventricular outflow tract. And we have to measure the diameter of the left ventricular outflow tract. Then we can, of course, here we measure diameter. Then we measure the flow. And then, of course, we can compute the cardiac output in these patients. The problem is that a small error in the diameter of the left ventricular outflow tract may induce quite a significant error in cardiac output. So relative changes will be much more reliable than really looking just at the absolute value. And of course, it's better just measure once the cardiac output and then to fix this measurement and not to change each time you measure it, because the left ventricular outflow tract diameter will not vary over time, rapidly at least. And some people have challenged the value of the ECO in this meta-analysis, and indeed, when you look at this, you say, oh, it's not very good. However, we need to look closely at it, because it was mixing apples and pears, meaning that it was mixing different ways to measure cardiac output by ECO. And if we focus only on the measurements of the left ventricular outflow tract here, you can see here that the agreement is much better, below 30% in most cases. So which is totally in opposition to the conclusion of the authors that also look at other ways to measure cardiac output, including the Simpson method, including the volume determination, including many other factors they use to compute cardiac output. So when you look at the most accurate way with ECO, it seems indeed to be accurate enough to compute cardiac output. So it is reliable. It gives you additional measurements, which is quite important. You have the full cardiac evaluation, of course, with echo. The problem is that you need to have some skills and somewhat time-consuming, admittedly. And the most important limitation, of course, it is intermittent, once again. And this, of course, is a major limitation. So what I like to do is to combine echo measurements with other measurements, which are nurse-driven and can be obtained easily. I will rapidly go over bioreactants because I don't have the time at this stage. And I will mostly look at the end, which is what do I do? Well, I interpret my cardiac output because I measure it with many other factors. And this is probably the most important aspect in the interpretation of the cardiac output. We need not only to look at cardiac output itself, but also to look at SGO2, but also to look at the other factors like the pressures and the volumes that can be determined by our additional measurement. And so the choice of the hemodynamic device should be based on the reliability on one hand, on the cost on the other hand, invasiveness, of course, because this will depend on the patient we have in front of our eyes, and more importantly, in the need for additional measurements for a given patient. And with this, I thank you for your attention.